morning, everyone. I am delighted to welcome you to today's session on pediatric anesthesia on the breakfast at where we will delve into a critical topic, the challenges of managing the pediatric airway during drug-induced sleep endoscopy or DISE. Our speaker today, Dr. Vinod Laxmikanth Balasundra, is the clinical specialist of the Department of Anesthesiology who bridges the gap between anesthesiology and pediatric sleep medicine. With his experience in complex airway management, Dr. Vinod will bring us through insights into optimizing safety and efficacy during DISE, a procedure vital for children with persistent obstructive sleep apnea or OSA. So Dr. Vinod's presentation entitled Challenges of Navigating the Sleeping Airway, Anesthesia Insights from DISE in Children will unpack the key considerations for these procedures. Dr. Vinod, the floor is yours.
Okay, good morning, everyone. I'm going to be sharing my slide. Thank you so much, Prof. Chaw, for that kind introduction. But today we're going to be talking about the challenges of navigating the sleeping airway and some of our insights from the anesthesia department with regards to drug-induced sleep endoscopy in children. Now, drug-induced sleep endoscopy is pretty well established in adults, and there's quite a lot of guidelines, protocols, and it's commonly practiced. But these protocols, guidelines, and the practice of DISE in adults is not really translatable to children. And we'll go in deeper into this topic to see why that is. So drug-induced sleep endoscopy, or DISE, is a procedure involving endoscopic examination of the anatomical structure of the airway whilst the patient is under a drug-induced sleep state. So this is the critical part to understand, that we are trying to mimic normal sleep as much as we can to identify where exactly along the anatomical structure of the airway there seem to be problems or obstructions particularly. So for children at high risk of persistent obstructive sleep apnea or OSA, example, children with obesity, children with severe OSA, which we don't really know what is the cause for it, Down syndrome, children with craniofacial abnormalities, example, those with Pierre-Robin sequence or Treacher-Collins syndrome, those with hypotonia or any neuromuscular disorder or any other neurological impairment. So in these children, as you can tell already, the cause of the obstructive sleep apnea is not purely obesity, but comes under a range of structural abnormalities as a result of the underlying syndromes and other problems that they may have, as compared to adults, which often the cause of obstructive sleep apnea is usually obesity. So now, what is obstructive sleep apnea in children? Now, the prevalence of OSA is about 1 to 4% in Malaysia, and it's defined by the presence of sleep-disordered breathing symptoms and apnea-hypopnea index of 1 event per hour, more than 1 event per hour, okay? And the symptoms of this upper airway obstruction are like snoring, witness apnea, difficulty in breathing, abnormal sleep posture, mouth breathing, excessive sweating. And the complications of this OSA, apart from what is listed here, example, elevated blood pressure, enuresis, excessive daytime sleepiness, cognitive deficits, academic difficulties, failure to thrive, morning headache. Actually, OSA in children has impact on their metabolic, their physiological state. It has impact on their lives in general, and so it is something that is worth taking note of. Screening for OSA in children is quite difficult. It's quite difficult, and it's different as compared to adults. Okay, so as I mentioned earlier, these are some of the conditions that you would consider screening children for OSA, or obstructive sleep apnea: obesity, prematurity, adenotonsillar hypertrophy or family history of adenotonsillar hypertrophy, nasal septum deviation, allergic rhinitis, craniofacial abnormalities, problems and abnormalities with regards to the face that they have, maxillary, mid-face hypoplasia, mandibular hypoplasia with or without cleft palate, neuromuscular disorders, and complex disorders. So there's a whole range of problems in children that put them at a preponderance for OSA, and we need to be vigilant and sensitive to these problems and think of OSA as a possible problem that may have been missed by the parents. So this is an example of a questionnaire that we utilize to screen children for OSA. And if you notice, this is different from adults. Adults use the pediatric, adults use the stop bank questionnaire, but we use the pediatric sleep questionnaire, all right? So there are 22 items in the pediatric sleep questionnaire. I'm not going to go through all of it, but just to mention a few, it talks about how the child is like when he's sleeping, what the child is like when they are awake, and what are some of the symptoms that they often seem to have. And some of the symptoms tend to be hyperactive in nature rather than somnolent or sleepy or lethargic in nature. So it's different in children. So diagnosis. So it's already pretty clear that OSA in children is something that's difficult to screen, and now we come to the diagnosis of OSA in children. Now, the gold standard is polysomnography or sleep studies, but as you can well imagine, it's resource heavy. You need a sleep lab to do it properly, and there's difficulty in conducting the study in children with all these wires and all these monitoring tools, and children often are not very compliant and they can't get a good result from this polysomnography in children, especially the younger the children are, or in children with behavioral problems and who are syndromic. Sometimes they have other associated behavioral issues, autism, and things like that, which makes it difficult sometimes to conduct this sleep study effectively. So there are other options, overnight pulse oximetry, which records the saturation of oxygen in the child while they are asleep. But this also requires sufficient recording capacity and staff that are trained and a dedicated environment to ensure that the recording is accurate and does not misdiagnose or result in false readings. But polysomnography and overnight pulse oximetry may tell us that the child may have OSA or diagnosis of OSA in children, but it doesn't really tell us the cause for the obstruction, particularly in children, as I mentioned before. The obstruction can be at various levels of the airway, and often in children, studies show that when they have obstructive sleep apnea, the obstruction is multi-level, not just at the upper airway, but maybe even lower down, maybe in the nasopharynx, maybe in the velum, maybe in the lateral pharyngeal airways, maybe adenoid-related, tonsil-related, or laryngomalacic even. So there are various levels and sometimes even multi-levels of obstruction. The other option is flexible fiber optic nasopharyngoscopy, and my ENT colleagues would tell you, particularly in pediatrics, it's difficult to perform on an awake child. And obviously, this does not mimic the conditions of the airway while the child is asleep, because when you're doing it in a clinic or in an outpatient setting, the child is awake. And so flexible fiber optic nasopharyngoscopy in an awake child doesn't really contribute much in terms of diagnosing OSA or where these obstructions are at when the child is asleep. Induced sleep endoscopy usually is implemented when after adenotonsillectomy, the children have persistent OSA. Now, there are instances and in different centers, sleep centers, where they do DISE prior to adenotonsillectomy, but they find that the outcome isn't so great because sometimes after adenotonsillectomy, the results are either lackluster or they may even exacerbate the obstructive sleep apnea. So they find that DISE after adenotonsillectomy has already been done and seeing that the child has persistent OSA symptoms, then we can consider utilizing this procedure to determine what exactly is the cause of the obstruction, seeing that the tonsils have been already removed. So the first challenge was with regard to diagnosing, screening these children for OSA, but the challenge number 2 is handling the difficult airway. So children who are screened for OSA, who are diagnosed with OSA, who have OSA, often the problem is not just simply obesity, but they have craniofacial abnormalities, neuromuscular disorders, and in summary, all of these instances where they do have OSA, it confers the fact that this child is a difficult airway. So this is a major challenge for us who are in anesthesia, who are handling the child to ensure their safety throughout this diagnostic procedure, to make sure that we are able to cope and manage the anticipated difficult airway that we're going to face. So often they have structural abnormalities, a receding chin, low set ears, Pierre-Robin syndrome, often almost having no chin, and all this is a nightmare for us who are in anesthesia, because we know that these are difficult airways, and now that we are putting them under anesthesia or under sedation, these difficult airways will show their ugly face, and so we must be ready. So one of the reasons for the fact that we have to be ready for managing the difficult airway is this kind of anesthesia is often what we call a tubeless field anesthesia. Now, as you can imagine, the drug-induced sleep endoscopy requires that it's a means of diagnosis. So they need the child to be asleep, almost mimicking their normal sleep, and there should be nothing in the airway, because that is not mimicking what is normal. So the airway is not secured, in other words, so that they can go through the nasopharynx or go through the oral cavity and do the necessary investigations and assessment of the airway without anything in the way of their view or obstructing the airway directly and interfering with interpretation with regards to the obstruction. So, as you can well imagine, when the airway is not secured, this confers a high risk of problems occurring if, in the event of desaturation, in the event of hypopnea, in the event of apnea, or in the event of overt obstruction. And we must be ready to rescue the airway. We must be ready to manage the airway. We must be ready to cope with whatever desaturation that is anticipated because of their obstructive sleep apnea. So they may be difficult. It may be difficult to mask ventilate them, difficult to insert a supraglottic airway or laryngeal mask airway. Often they are difficult to intubate. And they are above and beyond all this, or undergirding all this, there's unique considerations pertaining to the characteristics of the pediatric airway anatomy itself, which is different from the adult. For example, the voice box or the laryngeal inlet or the glottis is higher and more anterior usually in the child, especially the younger they are. And this itself confers some difficulty. Often they are, even in a normal child, the tongue is larger in relationship to their oral cavity, and their occiput or their head is large compared to their torso. So this confers all kinds of unique characteristics that we need to accommodate for to manage the airway. Challenge number 3, mimicking normal sleep. Because I mentioned before, there's no point putting the child under general anesthesia or allowing the child to just be mildly sedated, because this will not mimic what is the conditions they are in when they are usually sleeping, and therefore whatever obstruction they may be having in this awake state or in this general anesthesia state will not be what is occurring when they are normally asleep. So we want to mimic these circumstances as much as we can. So normal sleep. Normal sleep would mean that they are spontaneously breathing. We don't want them to be aware. So drugs we use should not exaggerate or exacerbate whatever obstruction that may occur with their natural sleep. We should be minimizing any secretions, because as we put them under anesthesia, put them under sedation, whatever drugs we use should not be causing them to have more salivation, example, or more mucus production, because this is abnormal. This is not their normal conditions during sleep. Also, we want to avoid them from having, from bucking, from coughing, from reacting to instrumentation, because this is something that is abnormal, isn't it? We are trying to mimic normal sleep, but at the same time, we are doing something abnormal. We are putting in a scope. We have all these monitors on them. So the introduction of this flexible scope into their nose, into their nostril, when it touches the pharynx and all that, this is very stimulating often. And this can result in coughing, bucking, and abnormal interpretations, or the difficulty to interpret what exactly is the nature and the behavior of the airway anatomy in this child. And on top of all this, we want to maintain stable hemodynamics, because every drug that we give in anesthesia will have some effect inadvertently on hemodynamics. So as you can tell, it's a very, very complex and intricate procedure from an anesthesia point of view. So if you look at the pictures here, these are some examples of what the operator and those of us who are in anesthesia will also have the privilege of observing on the screen as they go down the airway at different levels of possible collapse. Okay. So challenge number 4, managing anticipated hypoxia. Now, as I mentioned earlier, it's a difficult airway. We are trying to mimic normal sleep. We don't want them to react to any instrumentation, because reacting to the instrumentation may not just cause coughing and bucking, but it may also cause laryngospasm, bronchospasm. And in a child that already has problems with their airway, hypoxia is a real risk. And in children in particular, when they develop hypoxia, there's a increased risk that they become bradycardic very quickly, and this can lead to untoward circumstances, an emergency scenario where we are not just rescuing the airway, but we are trying our best to oxygenate the patient. So we have to be careful about the level of sedation that we are giving, how much we are causing the patient to be sedated, and we do not want the patient to be hypopneic or apneic throughout this procedure, because this will result in hypoxia, which we do not want. So children, and particularly those with obstructive sleep apnea, they are prone to desaturation. I mean, that's the nature of the condition. Obstructive sleep apnea means that when they are asleep, they will desaturate. And like I mentioned, there'll be risk of laryngospasm, risk of bronchospasm, risk of apnea, and quick to turn bradycardic. Challenge number 5. Now, this is with regards to our institution, this is with regards to practice in general, but like I mentioned earlier, the practice of DISE and anesthesia for DISE in adults is pretty well established. And even in our own, in UMMC, we have an established protocol and guideline with regards to DISE in adults. And this is aligning with international practices. But with regards to children, the practice has been fairly new in comparison to adults and slow in its development. So therefore, there's no existing protocol or agreed consensus with regards to, especially for the sake of our topic of discussion today, with regards to anesthesia protocol for DISE in children. So this makes it difficult for us to compare with other centers to see what's the best, because there are many, many ways to approach DISE for children. So there are still many unresolved issues in the use and usefulness of pediatric DISE. So that's why this practice also is somewhat just gaining traction. Sometimes, although doing DISE-specific directed surgical procedures, they find that the resolution of OSA may not be as what they anticipated. And so, and in some centers, or in a lot of these centers, there's a lack of pediatric anesthesia support who are well versed or comfortable with approaching the intricacies and the difficulties and the complications, the complicated nature of this procedure. And so there's a lack of pediatric anesthesiology support. And so DISE is not practiced as much in some of these sleep centers. And so there's a lack of evidence, lack of studies to establish some of these guidelines. And majority of the studies that are already available are actually retrospective in nature. So it's clear, anesthesia for DISE in children is therefore a complex and intricate balance of navigating these challenges. Now, this busy slide just simply shows you, in all the studies that have been done, the various ways that DISE and anesthesia for DISE can be approached. There are some that use inhalational agents, different kinds of intravenous agents, and with different kinds of outcomes and different kinds of results, different kinds of protocols, some using infusion, some using boluses, some using benzodiazepines, things like that. So it can be approached from various ways with often varying results. Now, these are some of the effects of the agents that we use in anesthesia on the airway. Now, like I mentioned earlier, we want to conduct anesthesia for DISE in a manner in which that we minimize any alteration to the obstruction along the entire tract of the airway. So as much as we can, we want to avoid it. But unfortunately, almost all of the agents will affect the airway in one way or another. And even if it doesn't affect the airway, it doesn't mimic sleep as best as we would like. Or if it mimics sleep and it doesn't affect the airway as much, but it has other problems like causing bradycardia, causing hypotension. So it's quite a complex, and often a single agent is not sufficient. So for example, in our setting, we tend to use, there are some of us that use dexmedetomidine and ketamine boluses as a means of conducting anesthesia for DISE. But these has its considerations as well, because dexmedetomidine, for instance, it's a bit slow in its pharmacokinetics. So it might be slow to result in sleep, and therefore, in the event where the child is too asleep and we want to wake them up a bit more, it might be slow to wake them up. For instance, dexmedetomidine also sometimes can cause a bit of bradycardia. Ketamine causes some hypersecretion and sometimes causes an increased tone in the upper airways. So not a perfect agent either. Some of us use propofol and remifentanil. That's what I do. And propofol is great. It's fast. It's a short acting, but it also can depress ventilation and cause some exaggeration of the airway obstruction. And so can remifentanil. But remifentanil is great in terms of protecting from the cough reflex, the bucking, the reactive airway. And so some of us prefer that. So it's about striking the balance and walking the tightrope of anesthesia for pediatric DISE. Okay, these are some considerations. Perhaps you want to use Thrive, transnasal humidified rapid insufflation ventilatory exchange, okay, or high flow nasal cannula, in other words, or intermittent mask ventilation. So when the child desaturates, not because they are hypopneic, not because they are apneic, but because of the nature of OSA, they tend to desaturate. We may need to intermittently take over the airway, insufflate with oxygen, support the airway, give a increased FiO2 of inspired fraction of oxygen to allow for the child to resaturate back to 100% before proceeding with the procedure again. We need to consider perhaps the use of anti-sialagogues like glycopyrrolate. Consider whether we really need sevoflurane as a volatile agent. Often children, they come sometimes without an intravenous line access. And so we use the volatile agent to induce the children and allow for access of intravenous access insertion. And then we subsequently stop the sevoflurane and continue with our intravenous agents because sevoflurane is not very good for assessing the airway, particularly when the airway is not protected. So you can imagine that once you put the volatile off the child, the effect of the volatile decreases quite rapidly. And so the child can wake up very quickly. So often we tend to go with a monitored anesthesia care approach or a total intravenous anesthesia approach using these agents, as I mentioned, propofol, dexmedetomidine, ketamine, remifentanil. And some of us will use depth of anesthesia monitoring as a gauge, example by spectral index, BIS, or SET-line. And this is, in children, again, this is tricky because there's no established consensus with regards to what's an appropriate target. And often the EEG picture in children with regards to depth of anesthesia monitoring differs a lot from the adult. And so there is some level of discernment and judgment, but it does help, I find, with at least recognizing a trend of what the child was like prior to putting asleep or when they were not so deep and under sedation, and then looking at the trend and deciding from there. We're almost done, and I'm going to open for questions. Just the next slide is to show you an example of a case that we did. So there's a video that's going to play, I hope. A 5-year-old ex-prem with Apert syndrome. So you can tell it's a syndromic child. Coronal suture, craniosynostosis, which was uncorrected. So this is a scary picture because this craniofacial abnormality is uncorrected. Bilateral choanal stenosis, which thankfully had some nasal dilatation done, although not optimum. And the child has severe OSA, started on CPAP, but non-compliant. You see the difficulties in the children. They're not compliant to CPAP. They're not compliant with regards to a sleep study. This child has a tiny patent foramen ovale. So hemodynamics is a consideration. And like I mentioned earlier, in this child, this was the case. Polysomnography was, we couldn't proceed with it because the child was uncooperative. So thankfully, the child had IV access and we proceeded with intravenous induction of anesthesia. We gave anti-chelagogue at the start. Then we subsequently started with a remifentanil at a very low dose at a mass rate infusion, and we titrated accordingly. And then we proceeded with the propofol infusion at using a pharmacokinetic model called the Pete's Fusor model. And then we used depth of anesthesia monitoring, and we were able to target a SET-line figure of 52. And DISE was conducted, and these were the operative findings. The video is lagging, I think, a bit, but these were the operative findings: bilateral nasal synechiae, retropalatal 100% complete anterior posterior circumferential collapse. The base of the tongue 75% collapse, even with a chin lift. Sometimes they do these maneuvers during the procedure to see what is the behavior of the airway when these procedures are done and to see the extent of obstruction. But thankfully, the other parts of the airway were quite all right. But as you can tell, there's already at least 2, if not 3, if you include the nose, of levels of obstruction. So DISE is definitely useful in determining what is the obstruction, where are the levels of obstruction, and what is the extent of obstruction. As an anesthesia team, it is our job to facilitate this procedure, but first and foremost, ensure that the child is safe. All right. I believe that is all I have. Prof. Chaw?
Thank you, Vinod, for his interesting talk, which especially relevant to us anesthesiologists, the ENT surgeons, as well as the pediatricians, striving to refine the perioperative care for children with condition like OSA. Quickly, we have 2 questions from Prof. Tunku Sarah. Why does OSA give rise to excessive sweating, as well as since the procedure is the causes are anatomical, wouldn't an MRI be good enough? Vinod?
Okay, if I heard the question, the first question, why does OSA result in excessive sweating? Now, as far as I understand it, when the child is obstructed and then they desaturate, the body tries to compensate this with a sympathetic surge to try and compensate for all this desaturation. The body, in other words, is under stress, is under undue stress during these periods of desaturation, during these periods of hypoxia, and during these periods where they're not getting adequate oxygen and air into their system. And so one of the manifestations of that often is sweating. Sometimes in adults, they'll complain of nightmares, very disturbed sleep, things like that. So, yeah, that's
Okay.
my understanding as with regards to I
think the
yes, Prof.
second question's MRI and the rate of treatment. I think the ENT surgeon would be better to answer those questions.
Correct.
Okay.
Correct. But in my reading so far, on the study that have been done, MRI is one of the possibilities, but this also is usually done in sort of a induction of a sleep state and then doing the MRI. But they still find in terms of real time looking at the airway dynamics with direct visualization appears to be more helpful in terms of the definitive the idea and the impetus for definitive surgery. And from what I can tell from the studies, the proceduralists or the surgeons are not very comfortable with just basing their definitive management on purely an MRI. So, but yes, the ENT surgeons will be best to answer this question.
Okay. Thank you, Vinod, for the answer. And because of the time constraint, I think I would like to conclude the first session. Thank you, everyone, for the questions and your attention. I would like to pass over the time to Dr. Amira, which will moderate the second session. Thank you.
Thank you, everyone. Thank you very much, Prof. Chaw.